Welcome, fellow colleagues. This is Dr. Jaitly on your source of learning, MuniMeterHealth, the source for cardiology and human heart illnesses and awareness. So welcome again on MuniMeterHealth. Just like I always say in a short video here, we're going to be talking about, does routine anticoagulation in heart failure improve the survival or the stroke incidence? So let's understand that very briefly, that this stems from the hypothesis that if the ejection fraction is less than 40%, the chances are in that LV there is some evidence of, we used to call it LV smoke at one point of time. So this used to be a sign, or is a sign actually, on an echocardiography, where one sees a stagnation of blood that tends to occur within the left ventricle here. And that is because the EF is profoundly low. It could be 20%, 15%, that's commonly seen. The lower the EF, you'll see a little ultrasonographic shadow, or if you will, the graying in the left ventricle within the cavity, signifying that the blood is starting to stagnate in the left ventricle. So anyway, so the hypothesis was that the lower the EF, the higher is the chance of having a stroke, and stroke can be fatal. So this study was done in France, and it included approximately 5,000 patients. It was published in New England Journal of Medicine just recently, and what they did was it was double-blinded. So remember that it was double-blinded. So that was a good part. So nobody knew what was going on, and these patients were randomized to a placebo, obviously, against a direct anticoagulation called. So a direct anticoagulation, if you will, that was rivaroxiban, rivaroxaban. Now this is a newer drug. It was 2.5 milligrams twice a day that was prescribed to these individuals, and they were followed roughly for about approximately 20 months. And when these patients were followed, they determined that against the placebo, there was no difference in all-cause mortality. So the mortality remained the same in both the groups. So it was equal. However, there was slightly lesser incidence of CVA or stroke in these individuals, but even then the mortality remained the same. So one of the things that really came out of this, by the way, this was not a free of any cost. There was some bleeding involvement here. So there was the bleeding incidence went up here in these patients who received a direct anticoagulation oral therapy with rivaroxiban 2.5 milligrams BID as opposed to placebo. Now all these patients had an ejection fraction of 40% or less, and they were randomized, they were double-blinded, approximately 5,000 patients. It was published in New England Journal of Medicine. So the take-home message, we also recommend, as many other sites will, that at this point, routine anticoagulation with a direct anticoagulation therapy is not recommended unless these patients have other indications like atrial fibrillation. Now, mind you, all these patients, they had an EF of 40%. They were also in normal sinus rhythm, and they had coronary artery disease. So remember, so these were the common things. EF was less than 40%, they had coronary artery disease, and they had to have normal sinus rhythm and no atrial fibrillation. Remember, if you have an AF, if somebody has an AF, automatically it is an anticoagulation. So there are no questions asked unless there was a contraindication for anticoagulation, then you would not prescribe. But the whole idea is wanting to assess whether these patients who are in normal sinus rhythm, who do not have any other indication for anticoagulation, but have coronary artery disease, do they perform as good as the placebo? And the answer was yes. Mortality-wise, yes. The incidence of CVA was slightly lessened, but the bleeding, again, it came at the cost of a slightly higher cause of higher numbers for bleeding. And as I said, so this was published in New England Journal of Medicine, and we give credit appropriately, as you see. So please review this article in detail, and of course the guidelines remain very clear, and I always refer to the American College of Cardiology for the guidelines. I thank you so much again. This short video vignette was primarily for the MDs, the DMs, and the postgraduates who are taking exams. So this way they have an idea. And plus, of course, colleagues like me who tend to always teach and learn at the same time. So looking forward to meeting you again on MuniMeterHealth, your favorite site, on your next video. Thank you.